The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case.
Welcome to the Allo podcast from the Allo Hope Foundation. I'm Bethany Weathersby.
And I'm Molly Sherwood, looking nice and jaundiced today.
Yeah, what's happening? I look like I'm straight out of the ice river from Frozen. And you're giving Donald Trump vibes with your face.
I think it's this lighting in my mom's house because I have to be here because my internet is just not going to fly ever again.
Yeah.
But also, I'm wearing that tinted moisturizer you sent me that one day. Remember?
Oh, yeah. Yeah, you look fantastic.
Yeah.
Yeah.
Anyway, it's just lighting and Trump vibes and tinted moisturizer. And that's the key.
Perhaps some hyperbilirubinemia going on?
Maybe
I don't know.
Maybe you were underlying liver condition.
If you were a baby photo sent to me, I would be like, hey, when was your last Billy check?
I know. Isn't it funny how that's how we think now?
Yeah.
It's like, how can everything in my life be applied to HDFN?
Oh, no. You actually look very tan and full of life. You look beautiful.
That's great. That's how I feel.
True.
Sometimes.
Good.
Rarely, actually, but you know.
Yeah.
Okay. It's time for another quick and dirty mini episode. And today we're talking about one of the more advanced and also lesser known treatments for HDFN, which is plasmapheresis.
Right. And I think our listeners probably know by now that we do not shy away from complicated topics, right? Because the more we understand, the more likely we are to have a healthy outcome. And so this treatment actually played a crucial role in my own baby survival. So I'm really excited to kind of give it some more attention today. Okay. So with that said, let's just head on over right over to Nerdland and chat about plasmapheresis and somehow keep it short. Keep the
I believe
nerd
in
out
us.
session short.
I think we can do that.
Okay.
And also, if we have any new listeners, I would recommend going back to season 1, episode 6, to listen about the myths and management of severe disease episode to learn more about when this is used for severe early onset HDFN.
Mm-hmm.
Okay, let's start with some blood basics. We've really immersed ourselves in the blood world lately, haven't we?
Mm-hmm. We have. We've been fully immersed in blood.
There's so much.
Just covered in blood.
Just covered. Oh, okay.
I don't know what's happening.
Okay, looking at some blood basics. Blood is made up of 4 main things, 4 components: plasma, red blood cells, white blood cells, and platelets. And the plasma makes up over 50% of our blood volume. The plasma is actually the liquid part of our blood, and it carries the other 3 components in it suspended in the liquid.
Like kind of like cereal.
Yeah, I don't really know why we had to compare it to cereal, but it's not wrong.
I mean,
can't disagree.
Right. You know, like this morning, my kids, well, I didn't make them a fantastic breakfast. I'm just going to admit it here. And so I was like, we're having cereal because we have to get to school quickly. And so one of them had Raisin Bran with added almonds. Okay. It actually looked really good. So
platelets.
This is, yes, there you go. Thank you.
Yes.
Thank you for going there with me in your brain, coming into my picture
Our
world.
brains just fused for the almond platelet analogy.
Raisin. Yeah. Okay. So the milk is like the plasma, right? And then it carries the other components in it. Let's say the bran flakes are the red blood cells. The almonds can be the white blood cells, and then the raisins can be the red blood cells. So they're in that liquid, and blood cereal.
Oh, delicious. So good.
Yeah.
Anyway, I'm not sure if I'm ready to think about blood cereal anymore for this episode. So the red blood cells, white blood cells, and platelets are floating in the plasma. And the plasma also contains antibodies and clotting factors that help to control bleeding.
Right. Okay. And now just one more quick, we're going to go off track a tiny bit. Eric,
Let's
don't
go.
roll your eyes back there. Okay. We're going to do it on time. Um, but when I was kind of researching for this episode, I learned that, okay, the plasma makes up over 50% of the total blood volume, which makes sense. It's the liquid portion. But then I found out that the red blood cells make up 40% of the blood volume, which I did not know. And that, like, it was like a light bulb moment where I realized, oh, that's why when those red blood cells are destroyed by maternal antibodies, there's a noticeable difference in the thickness of the blood, right? If it makes up 40% of the volume, if you're destroying it, you're going to have less viscous blood. Is that the right word? I think it is. Anyway, it's going to be thinner blood and therefore flow quicker. And when you monitor for fetal anemia, you, with an MCA Doppler scan, you're looking at the flow of blood and the rate of flow. And if it's flowing too fast, that's how they know that the baby is probably anemic. So anyway, it just was like a nice connection to understand that that's why, because it's 40% red blood cells.
That's a cool fun. You're so good at at creating visuals, you know? Now
Yeah,
I have a visual of that.
Yeah.
Okay, let's actually talk about plasmapheresis.
Okay. Okay. Yes. Okay. So let's get back to our quick and dirty. All right. Plasmapheresis is also called therapeutic plasma exchange, or TPE, and it's a procedure that removes a portion of a person's blood plasma and then replaces it with either a plasma substitute like albumin or occasionally donor plasma. And remember that the antibodies are found in the plasma, so removing plasma means you're removing antibodies as well. And so plasmapheresis can help temporarily lower the levels of maternal red cell antibodies that could potentially cross the placenta and destroy the fetus's red blood cells, causing that fetal anemia we want to avoid. Unfortunately, plasmapheresis doesn't really fix the underlying issue because, as we know, once a woman is sensitized, she's always sensitized. She'll have those antibodies for the rest of her life. But plasmapheresis can significantly reduce the concentration of antibodies during those critical weeks of an alloimmunized pregnancy when intrauterine transfusions are very risky.
So the goal of plasmapheresis is to basically buy the baby some more time before they need intrauterine transfusions. And this is especially important for those at risk for early onset severe fetal anemia because survival rates are much higher for babies who have their first intrauterine transfusion after 20 weeks versus those who have had them before 20 weeks. There's one study that compared outcomes of 491 fetuses who had a total of 1,422 intrauterine transfusions.
That's so many.
That is awesome. It's super hard to find studies with this many
I think
IUTs.
it was Leiden. I think it was actually, but we'll put the
Classic.
Yeah, I think it is.
Oh yeah,
we'll
I see
put
it.
the
Yep,
reference.
it sure is.
Yep.
So of the fetuses who had their first IUT after 20 weeks, 92% survived. And of the fetuses who had their first IUT earlier than 20 weeks, 76% survived. That's a big difference.
That is a big difference. And I do want to add that this was over 10 years ago, this study. So I think it was published in 2013. And it said in the study that survival rates are now higher for the babies who had later IUTs. But the fetuses who had their first IUT before 20 weeks, the survival rate has not changed, actually. So that was interesting.
That's really
because we typically don't see that 92% survival, right? I mean, it's usually higher. So that was so interesting. Wow. Okay, so and can I just quickly say with my case, so I had 4 severely affected pregnancies. Only one of them needed an IUT earlier than 20 weeks, and she did not survive. And then with plasmapheresis and IVIG, the others didn't need their IUTs until 24, 25, and 28. Those were their 28 weeks. Those were their first IUTs, and they're all totally healthy. So anyway, it really did make a difference for my children. So let's walk through what the process actually looks like. So during a session of plasmapheresis, a mother is connected to a machine via IV lines through a central line or a permacath, we called it a permacath. I think that's the same thing. And coming out of the chest, there's 2 lumens, and you can see here in the photo what mine looked like. And so there's one that's used to pull the mother's blood out, and then the other one is used to return the blood to her body. And you can see the 2 lumens coming out of my permacath. And so the mother's blood is drawn out. It's run through a machine that separates the plasma from the rest of the blood, and then the red cells are returned to her along with the replacement fluid that I mentioned earlier. Typically albumin. Some places use donor plasma. And here's a quick video of me having plasmapheresis during one of my pregnancies. And the machine is very loud, as you can hear. Oh, and here is a photo. Sorry, Molly, I don't have the photo for you, but have you seen the bag? Have you seen the bag of my plasma?
I've seen the bag.
It's disgusting. Okay. And here's a picture of my plasma from one session that they pulled out of my body. But it's really wild how much they take from the mother. And another thing that was surprising is that sometimes the plasma is like yellow, sometimes it's green. Some people apparently have cloudy plasma. Yeah, kind of gnarly. But anyway, after the treatment's finished, they monitor the mother, take some labs to make sure that her calcium levels are okay and her blood clotting factor levels are okay. If they aren't high enough, they'll give an infusion to increase the levels before leaving the clinic. And it just takes, I think, I don't know, maybe a couple hours, 3 hours. And typically, plasmapheresis is done between 10 and 12 weeks gestation, which shows that you need to kind of get an early start on this, getting everything arranged. And the most used protocol is to do 3 rounds of plasmapheresis in a week with 1 day in between each treatment. So usually they're done on a Monday, Wednesday, Friday, and then IVIG infusions are started the day immediately after the last plasmapheresis treatment.
That makes a lot of sense because it's like the plasmapheresis is supposed to lower the antibody levels, and then while they're low, then the IVIG comes in. Cool. And we'll definitely discuss IVIG in depth in another mini episode. And also for anybody who's listening on a audio podcast platform, the pictures and the videos that you were just talking about will be on the YouTube version of this episode. Yes, good point. Okay, so now let's talk about who typically receives plasmapheresis during a pregnancy, an alloimmunized pregnancy. It's reserved for those at risk of severe early onset fetal anemia. So moms who have experienced severe HDFN in a previous pregnancy, which would be a mother who lost a baby to HDFN or had fetal anemia begin earlier than 24 weeks in the past, or also used for women with really high titers like yours, Bethany.
Right. And mine was 1,024 for Cal. So yeah. It's also important to point out that, like you mentioned, Molly, plasmapheresis is almost always used in combination with IVIG infusions. Plasmapheresis as a treatment on its own has not really been studied much for this purpose. And I think the few studies that they have on it show it to be less effective, far less effective actually, without the IVIG combo. And that's because when we remove that antibody-rich plasma, our immune system, which is so smart, seriously, it's always impressive to me. It notices, hey, we're low on these antibodies, and then it works hard to create more antibodies to compensate for the removed antibodies. So most women will have a 2 to 4-fold reduction of their antibody titer after plasmapheresis. So that's like, let's say my 1,024 titer could potentially be 256, right? But often there's a rebound effect where that immune system is trying to compensate, right? And so your titer can go back up. But when you have that IVIG, like Molly said, right after the plasmapheresis, it helps prevent that strong rebound effect and protects the baby from being affected early.
Yeah, good point. And also, plasmapheresis is not common. It's rarely talked about in the management of HDFN, and some clinicians don't use it, or they worry it may not be effective, or they need more evidence before they start using it on their patients. And it is true that plasmapheresis combined with IVIG has been proven to delay the onset of fetal anemia for those at risk for severe early disease. And IVIG alone has also been shown to delay fetal anemia. There is, like you said, though, very little evidence to show that plasmapheresis on its own is an effective way to delay fetal anemia.
Totally agree. And this actually reminds me of our talk at Kijabe Mission Hospital in Kenya, Molly, when we were there this past trip a few months ago, when we used the toolbox analogy. And I think it's something that most providers probably have to do kind of naturally in their work, but it can be a helpful way to frame HDFN care management. Each provider has to look at their own toolbox and see what they do have available, and then use those tools to the best of their ability to provide safe, effective treatment for their patients, or refer their patients to someone who does have the right tools. Because care access and resources vary widely, as we have seen, between medical centers worldwide, right? And so that just means that each provider might have different tools to work with when they're treating HDFN. And I do think that plasmapheresis can be a useful tool in the toolbox for some physicians, and for others, it's probably just not feasible.
I love that analogy. It's similar to how we've talked about and we've learned from MFMs that we really have trusted and deeply respect about how this disease is managed like an art. And it's a similar concept of like, what can I pull together with what I have to do it right for this specific case? So I think to kind of summarize some of these topics, if you're a patient considering plasmapheresis, here's a few things to have in mind. First is, this is really highly specialized care. You would likely need to transfer to an MFM, a maternal fetal medicine doctor, or a fetal therapy center that has experience using plasmapheresis in pregnancy. And that's also why it's important to ask about early planning, because these therapies require coordination and insurance approvals, and they happen early in the pregnancy. So timing is really key. And then here's a new one you've never heard us say. Advocate for yourself. If your previous baby had severe disease and you're already seeing high titers early in your pregnancy, do not wait for the disease to start harming the baby. Bring up plasmapheresis as a proactive option. And for providers, please consider consulting with experts early on in high-risk pregnancies, because plasmapheresis is not right for every case, but in the right scenario, it can dramatically change outcomes.
Yes, so good. Those are such good tips, Molly.
Thanks, you wrote them.
Well,
they're so good. I would have done the same.
Now everyone knows. They're still so good. Let me just say this. Because of my attention deficit hyperactivity disorder, I wrote this a while ago, this portion days ago. And so when you're saying it, it sounds new to me.
You're like, wow.
I'm like, oh, that's actually really good.
That is fun. I always feel that way when I'm reopening my Christmas decorations. I'm like, oh my gosh, I forgot about this. Yeah.
Exactly. So that's like a year between. And this is like days. Okay. So anyway, it felt like some good new material.
There you go.
Okay, and then I'd like to just quickly share a few practical tips for patients who are having plasmapheresis treatments. And I think we probably touched on some of these in the severe disease episode back in season 1, but just a good reminder to bring some really good snacks with you to your plasmapheresis treatment, and bring some something that you like to drink, water, whatever it is. It's really important to stay hydrated and try to boost your protein intake, because there is protein in the plasma that's being removed, and it's just really helpful to have that. And then bring something entertaining. Get, podcast, movie, maybe this isn't entertaining, but you can bring your work computer, do some work. It's very boring. Plasmapheresis is incredibly boring. And so just bring something
We like
fun.
boring. We're talking about this thing.
Well, no, it is fun to be without your children, though. Is that okay to say? I don't know. It's a nice rest, I will say. And on that note,
the blanket. Oh.
yes, so wear comfortable clothes, bring a cozy blanket or a heating pad. I loved my heating pad because when they return that blood to your body, it has been through a cold machine. It's cold. It's not really warm. And then you get like chilled from the inside. And so, it's not good. So it feels so nice to just be cozied up there. And then just want to say that I had almost no side effects. I mean, it did make me feel kind of like tired sometimes, but yeah, that was a nice part about it, was there weren't any terrible side effects for me.
Yeah, you totally got me on the heating pad train. I remember one time we were together in a hotel.
Oh my gosh.
Yeah. And you were like, oh, your hands are so cold. Here, lay on my heating pad. And I just felt like a warm baby. Like, it was just the best.
Exactly.
Anyway.
And that, my obsession with the heating pad started with plasmapheresis. Yeah. It's great.
Okay. Credit to plasmapheresis.
Yeah. There you go.
Okay. So if you're listening today and you're wondering whether plasmapheresis might need to be a part of your care plan, talk to your maternal fetal medicine specialist about it. You can also reach out to us at AlloHope. You can always email info@allohopefoundation.org. We see it, someone responds, and we can connect you and or your provider with experts who are happy to answer questions about plasmapheresis.
Absolutely. We did it, Molly. I think we kept this nice and concise.
Woo!
I'm proud of us.
Good job, us.
Yeah. Okay. Whether you're a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's allo spelled ALLO. hopefoundation.org. Thanks for listening. Yeah.
Oh, shoot.
Should we redo that? Eric.
The Allo podcast is offered by the Allo Hope Foundation, a nonprofit organization. This means that our ability to continue this work depends on corporate sponsorships, small research grants, and donations. While sponsorships and grants are vital, they're often restricted to specific activities, and they do not cover the everyday work that keeps our mission moving. Things like creating educational materials, writing grant applications, running our social media, and especially managing our rapidly growing patient support group where we counsel women every day. They also do not cover the direct support we provide to families who cannot access life-saving care, whether that's the cost of an antibody screen in Kenya or bus fare for a mom in the US who needs to travel for an intrauterine transfusion. If you've ever wondered whether a donation of any size makes an impact, it truly does. Please visit our show notes for information on how to donate to AHF or to become a recurring donor. Your support gives our small organization the stability we need to continue this work and ensure no family faces HDFN alone.